Today we are learning about the infertility. So how do you define infertility?
Infertility refers to inability of a couple to achieve a pregnancy after 1 year of regular unprotected intercourse in a woman of reproductive age who has never conceived before. The incidence is 10 to 15% in couples affecting globally.
Okay, how do you differentiate primary and secondary infertility?
And primary infertility is when the woman is never conceived, even after regular intercourse for 1 year. Secondary infertility is when the woman has conceived before and is not able to conceive the second time.
Okay, very good. So what are the different causes of infertility? It is male and female.
Yes, ma'am.
So what are the causes of female infertility?
Female factors usually 40 to 50%. Under that, it is ovulatory disorders like PCOS, that is polycystic ovarian syndrome. Then it is stress and excessive exercise, which is hypothalamic syndromes. Then premature ovarian insufficiency. Then tubal factors like blockage.
We will elaborate on the ovarian factors of the infertility. Okay. We majorly divide the ovarian factors of the infertility as oligo and anovulation is the first one. Second one is decreased ovarian reserve. Third is luteal phase defect. And fourth is luteinized unruptured follicle. So what is anovulation?
Ma'am, anovulation is menstruation without the release of ovum.
Yes. In the second half of the cycle, usually after the LS surge, there is release of corpus luteum. It releases the progesterone, and withdrawal of the progesterone leads to the menstruation. But in the anovulatory cycles, there is only estrogen which is building up, and at one point of the time, the arterioles fail to grow up to the endometrium, and the endometrium sheds off because of lack of the blood supply. This is oligoanovulation. What are the other causes of oligoanovulation apart from PCOS?
It may be endometrial hyperplasia due to other causes
Like thyroid and adrenal dysfunction. Okay. So what is luteal phase defect? Second cause is luteal phase defect.
In which the LH surge has not been the mark in the menstrual cycle.
Means the corpus luteum, which was supposed to get developed and it would have been stayed for next 14 days in the luteal phase, it is not staying. It is staying only for less than 10 days. Okay, it is not producing enough of progesterone. What are the causes of luteal phase defect?
Luteal phase defect is when the Graafian follicle has not
grown properly. What happens if the patient is is taking the ovulation induction drugs and there is hyperprolactinemia and other pelvic inflammatory diseases like endometriosis. Okay. The next cause would be
stress and
luteal phase defect. We studied luteal phase. Then next cause is decreased ovarian reserve and luteinized unruptured follicle. What is luteinized unruptured follicle?
I don't know.
The ovum which was supposed to get released, it is not getting released. It is still inside the Graafian follicle. It is called as luteinized unruptured follicle. Causes are pelvic endometriosis and hyperprolactinemia. Okay.
And there's one more cause, that is premature ovarian insufficiency.
What is premature ovarian insufficiency? The patient is having decreased ovarian reserve, which was supposed to get decreased by the age of 40, by the age of 52. Now it is earlier, she is having menopause, that is premature decrease in reserve. Okay. The FSH in her body is now more than 40. When you see the FSH level, it is more than 40. What are other factors apart from the ovarian factors now?
Tubal factors.
Yes.
Like blockage or damage due to pelvic inflammatory disease and endometriosis or previous surgeries.
Yes.
Or bilateral block in the tubal, in the fallopian tube.
Okay. So you should ask the history of any previous infections which might lead to pelvic adhesions, and it might lead to any endosulfans damage. Previous any tubal surgery, we miss asking those things because we think there won't be much of such things like sterilization. And salpingitis systemica nodosa. It is one of the complications where the mucosal folds, they grow up into the muscularis fold of the tube. Okay, and this condition is seen in the case of PIDs.
Yes.
There might be polyps and mucal debris which might be blocking the tube also. All these things has to be investigated. Next, peritoneal factors.
Many like endometriosis, then fibroids, then any previous surgeries done in the pelvic region.
So peritoneal factors are Mainly two things. One is endometriosis and second one is adhesions. Okay. Fibroids and all, they cause subserosal fibroids, they don't cause problem in the, they don't come into the peritoneal factors, they come into the cavity. If they're big, submucous fibroids, they alter the fertility. Subserosal fibroid, they don't play a major role here. Okay. Only two factors, those are endometriosis and adhesions. Okay. Endometriosis, what does it do? It alters the local biochemical properties, which won't which will make the ovum trapped inside the follicle. As we told, it also adds up to the ovarian causes like trapped ovarian syndrome. Okay. And this endometriosis, how will you elicit? They will have deep dyspareunia. You ask history of dyspareunia, they will have dyspareunia, and also adhesions. The patient will have dyspareunia. Okay. This points out toward the peritoneal factors. Uterine factors.
Congenital uterine anomalies, then fibroid and intrauterine adhesions like Asherman syndrome.
So, what is Asherman syndrome?
And in the uterus, there are a lot of adhesions which block the ovum to come in the uterine cavity and lead to infertility.
So, basically, there is no endometriosis for implantation. Okay. Why does Asherman syndrome occurs? If there are any previous history of abortions, they would have scraped the endometrium during that time, during the procedure of dilatation and curettage. At that time, they would have scraped the endometrium, which is now leading to the adhesions between the endometrial cavity. There is no space, first point, and there is a damaged endometrium. This is Asherman syndrome. It is one of the major uterine factor. Apart from this, the patient, if she has fibroid, one is the cavity is being distorted now, and the second is there is a local release of the cytokines and enzymes which will prevent the implantation to occur. And for the next very important factor that you will examine if the patient is not conceiving is, you will take the sample of the endometrial tissue and you send for CB NAT. Like you are suspecting tuberculosis, you have to suspect tuberculosis. That is it causes chronic endometritis, and it prevents the nidation of the embryo into the endometrium. Okay. Next cause is
congenital uterine anomalies.
Yes, congenital uterine anomalies. If it is a bicornuate uterus or septate uterus, again the space is decreased for implantation, and that causes has to be ruled out by scan, or you have to do diagnostic laparoscopy for that.
I mean, even if uterus is retroverted.
Yes, even if the uterus is retroverted, or if there is any cervical pinpoint os is there, or if there is any cervical elongation is there. Okay, even that anatomical factors, they matter a lot for the conception to occur.
Yes, ma'am. Next is cervical factors.
Yes.
Like insufficient cervical mucus production, and there's cervical stenosis, any infection in the cervix region.
So you have to do a bimanual examination to check for all these things. The chronic cervicitis should be checked, and you see whether there is any pinpoint hole is there, or you ask for any surgeries. Like they would have taken out they would have amputated the cervix, and they would have they do colonization, and they do deep cauterization of the cervix for chronic cervicitis diseases and all. So you have to ask those histories. Patient won't tell unless you ask them. Okay.
And even the cervical discharge, like purulent discharge.
Yes, especially the cervical discharge themselves, they don't cause any abnormalities, but they cause dyspareunia, which might lead to infertility. Next, vaginal factors.
Ma'am, we have to check for the anatomy of the vagina. Any congenital anomalies are present. Any purulent discharge again.
Congenital anomalies like
atresia,
transvaginal septum, vertical septum. Okay, and narrow introitus is very important. Narrow introitus is again the cause. You have to address for it. So you have to check the roominess of the introitus, and you have to ask whether there is any dyspareunia with that. Okay.